I see people are still working on joining, but we will go ahead and get started as I have 1 p.m. Eastern. So welcome back. It's great to see all of you for another week of Superior Health's COVID-19 Nursing Home Leadership Roundtable. I'm sure you know our core team by now, but for those of you who might not have been joining these calls, my name is Kelsey Ostergren, and I'm joined by my program co-leads, Jerry Hineker and Kim Haft. Today, we also have two Superior Health colleagues who will be leading a discussion about vaccine myths. If that sounds familiar to you, this was supposed to be a topic for our October 5th session. However, I know Kim had shared some sort of breaking news topics, which we had great discussion on. So unfortunately, we ran out of time for Gray and Yvonne. So Gray and Yvonne, thank you for being flexible. We're glad to have you back. And you finally get a chance to do this presentation today. As always, for our participants on the line, I want to just invite you to engage in the session and ask any questions you might have. These sessions are always COVID related, so even if there are sort of unrelated topics to what Gray and Yvonne are talking about today, I welcome you to ask that either via chat throughout the presentation or when we get to the Q&A at the end and just kind of have that open, informal dialogue about any COVID challenges or questions or things you're struggling with. I know with the group we have on the line, your peers and certainly the Superior Health team would be happy to kind of weigh in and talk through some of those pieces. The slides for our session today are available, and Jerry has just put a link to that in chat. And as always, at the end of the session, we will share a link to an evaluation and would appreciate your feedback to make sure that we are meeting your needs, and if not, what we can do differently. So before we get started, I just wanted to take a few minutes to sort of recap some of the recommendations about our bivalent COVID boosters, since I know our team has been getting a lot of questions about them, and frankly, there have been some misconceptions. So I figured this would sort of be a nice lead into what Yvonne and Gray will be talking about. But just to sort of like level set here, as a reminder, the bivalent COVID vaccines became available in September 2nd. And this formula was developed specifically to protect against our new Omicron subvariants, BA4 and 5. People 5 and older are eligible for Pfizer, and 6 and older eligible for Moderna. Related to timing, I think a couple things here I wanted to sort of highlight. So the one, I guess, requirement, if you will, is that you wait at least 2 months from your last vaccine. So whether that was part of your primary series or if it was, the original monovalent booster, either one of those, you would need to wait 2 months since then to be eligible for the new bivalent booster. If you actively have COVID, another reason you should wait to get this bivalent booster until your symptoms are gone and isolation has ended. The last piece here I just sort of want to draw attention to, and this is something that I think there's been a lot of confusion about, is when you should consider waiting. And so I know there's been sort of this thought maybe, about how soon after you've had COVID can you get the booster, right? So if your symptoms are resolved and if you've ended isolation, is that appropriate, or do you have to wait the 3 months? So that is a recommendation. It is not a requirement, but the guidance that CDC has put out basically says to consider waiting and delaying that bivalent booster by 3 months from whatever date you tested positive or those symptoms started. But again, just want to reiterate that is not a requirement. It's just something to consider. So if you are high risk, and for a lot of the residents that are in your facilities, perhaps waiting 3 months from that positive test doesn't make a lot of sense. Maybe you do want to do it, once our isolation has ended, or even like 6 weeks. That would certainly cut that time in half. So again, not a requirement, but a consideration, something to just kind of keep in mind there. Related to mixing vaccine product, a couple notes here. It's okay to get a different bivalent booster than what you got your primary series. So if you had a Pfizer primary series or a Pfizer initial booster, it's okay to get a Moderna bivalent booster. There really are no concerns about that. The other thing I want to just comment on our bivalent boosters is that it's okay to get the bivalent booster, even if you got more than one monovalent booster. So that does not preclude you from getting the bivalent booster if you had, say, 2 of the monovalent boosters previously. I think really the only restrictions around when you can get it would be related to the last vaccine dose or active or maybe recent COVID infection.
Yeah. Oh, sorry. Do you mind if I add a note real quick?
Please.
We always want to remind people to speak with their doctors if they have any individual concerns or if they still don't understand the requirements or any of the suggestions from the CDC and other public health experts. Sorry, I just always got to say it.
No, I appreciate that, Gray. Yes, and I think, this guidance is what the CDC puts out kind of as blanket, but as Gray mentioned, right, this is an individual decision and discussion. These are guidelines that apply to most people, but not all people. So again, if there are questions, certainly your physician or care team would be the most appropriate to sort of have those one-on-one conversations with. So a couple other points related to our bivalent boosters. So there are some new variants that are kind of hanging out there. These are BQ variants. And last I looked, these 2 variants were now accounting for about 12% of our COVID cases here in the US. For those of you who joined our presentation, gosh, a couple months ago now, where we were talking about BA4 and BA5 variants and how they were sort of evading immune detection, what we're hearing about these BQ variants is that they sort of kick that up a notch, and they are now even more evasive for our immune systems. So I think that said, we don't really know how effective some of our current treatments will be against these 2 variants. I think the good news here, though, is that what we believe is that our bivalent boosters will provide protection against these 2 variants because they're sort of descendants, if you will, from BA5. So we think the bivalent vaccine will be protective against them. And sort of on the flip side, we don't think, but we don't really know whether our current treatments will work. I think the other good thing that we're seeing with the bivalent booster is that it was designed to have this broader cross neutralization against future variants. So really, this is going to be helpful to extend the length of protection that we're afforded by this booster. So as we continue to see the virus evolve, we believe that this vaccine really will help us sort of lengthen that time period beyond maybe what we had seen with our monovalent vaccine. It's still pretty early at this point for us to really understand the full efficacy of these bivalent boosters. But the best data we have at this point is a study that Moderna published in the New England Journal of Medicine, which showed a significant increase in our body's ability to neutralize Omicron. And this was true both for people that previously had COVID infections, as well as those who did not. Beyond that, the antibodies that we produce as a response to this bivalent booster is better at neutralizing all of the variants that we are currently aware of. So I think that's pretty strong evidence in support of why these bivalent vaccines are helpful, particularly given that we don't know whether our current treatments will be effective at treating these. I think that said, so far, only about 1.5% of the US population has gotten a bivalent booster. And at this point in time from where we were when our original monovalent boosters were released, we were about 80%. So I think there's, sort of this drastic shift in, a couple months post vaccine release, right? We had much better uptake with our monovalent boosters than what we've had thus far with bivalent. So I want to just talk briefly about sort of why we're seeing this shift, and would ask you to contribute anything that you're seeing or hearing from, people in your facilities, people in the community, what you're seeing and kind of hearing in your area. So in no particular order, these are some of the factors that we've kind of picked up on and just wanted to highlight. So I think the first is related to public messaging. And because we're, almost 3 years into the COVID pandemic at this point, the messaging and the campaigns around COVID and COVID boosters, I think to a lot of us have become like background noise, and we're kind of like, we're drowning it out. It's not as, kind of front and center as what it used to be. I think that really goes hand in hand with COVID fatigue and just this widespread, I guess, lack of, really taking it seriously, and this almost like acceptance that it's just going to become part of everyday life. Like how we have flu season, we're just going to have COVID, and we've just kind of accepted that and are moving on. Really, to me, the biggest thing on this list is the urgency and the fear. And I think what that urgency and that fear that we had early in the pandemic really helped get folks vaccinated. And largely that has disappeared, I think. Back in late 2020 and early 2021, when some of these vaccines first became available, I think a lot of us were really fearful of the consequences of this virus. And now that people are feeling safer and there are treatment options and we're sort of back to normal life, the situation just feels different, and it makes sense, right, that there would then be like less urgency in general to get a vaccine. And, I sort of think about this with my public hat, my epidemiology hat on, and thinking about the high transmission and sort of how does that factor into this? And, as I was pulling some numbers for this presentation, in mid-October, nearly half of the US was in an area of high community transmission, with another about 25% that was seeing substantial transmission. So that's 3/4 of our country that was either in substantial to high spread. And so, I'm sort of thinking like, why aren't we worried about this? Why isn't this a bigger deal? And frankly, I think part of the problem is that the metric for community, use, that COVID-19 community level, says that 80% of our counties are in low transmission, right? So how do we reconcile this difference in what our community partners are looking at, which says it's fine, it's not a big deal, versus what we're looking at in healthcare, which is like, the red alert, like, hey, 3/4 of our counties are in substantial to high. And so that sort of stark dichotomy between healthcare and the general public, I think, has created confusion, for lack of a better word. And the last piece I'll mention here is just about bivalent vaccine side effects. So again, it's still pretty early. We don't have a ton of scientific data to confirm whether the side effects from this vaccine are in fact more severe than what we had seen with a monovalent booster. However, given the broader immunity that our bivalent booster affords, I think personally, it does make sense that we could see, more side effects as a result, right? And I think a lot of how we as individuals build this narrative right now is based around people around us who have gotten the vaccine and are sharing their stories, right? And so these anecdotal stories in lieu of any scientific evidence or data is really what frames our perception of risk or that narrative about vaccines. I think, the one piece to keep in mind here, right, is everybody's different. Everybody's going to respond different. Nobody's story is going to be exactly the same. And so, just understanding sort of your risk level, any underlying factors that you might have. And as Gray pointed out, having that conversation with your care team to really figure out, if you have concerns, voicing that to them and really asking for their guidance, I think can be immensely helpful. So with that, Gray, I will kick it off to you to go through our content for today.
So I just had to talk to myself while I unmuted. I see a very important comment here, but I think we will address that more towards the end if that's okay. But thank you so much, and I would continue to encourage people sharing what's going on. So today our objectives are to review vaccine myth stories, discuss problems with myths and stories regarding vaccines, and talk about possible clinical suggestions for individualizing responses. Because as we just spoke about, while this is a public issue, it does become an interpersonal and an intrapersonal concern. So it's those discrepancies between those, and then look at possible solutions for moving forward on how to rectify that and manage it through our fatigue, and then share patient and provider resources. So on to the next. Okay, so I use this quote very often when I am trying to figure out exactly what's going on, or when you have those moments when you're going to start a new brief or a new project of, okay, even no matter what I do, nothing is ever going to be perfect. Often, people who hear what they want to hear will hear what they want to hear, and then you can't control public perception. So in science, credit goes to the one who convinces the world and not the one to whom the idea first occurred. And that goes along with marketing and public rhetoric. While I am an epidemiologist, I also have a background in social sciences and language and communication and arts. So those all come together to show how I try to analyze larger picture issues, and hopefully help disseminate individual concerns as well. So we can move on to the next. And then root causes of myths in general, like Kelsey pointed out, people will get confused. And when people are afraid and confused, or people are often afraid when they get confused, the fear of the unknown, fear of difference, people will try to come up with solutions or rationalities to make sense of the world around them. And with science, most of it is nothing's ever 100%. We can only say that there's evidence for or against. There's no such thing as proof. Things always depend on the condition, the tools you have available, and how we have done things before or what we already previously know collectively. So there's a lot of fear of the unknown, which is very human. And we also, I think, what doesn't get discussed is not just new symptoms or new variants and things like that. It's also minimizing the threats of disease or minimizing what we don't know just because it's scary. What the reality is, we don't know what is going to happen in the next 10, 20, 40 years. We don't know how these viruses, next pandemics are going to be affecting future generations. So, and thinking about that, even when I say it out loud, makes me even emotional thinking about that. So I think that's why it's really easy to feel tired and forget that we need to take care of ourselves as much as we're working to care for our patients and our providers, our beneficiaries, and our communities, and how those definitions get built and understood. And then there's also that perception that goes along with that, that only people who are weak will be sick or affected, or, it won't happen here. That's across the county line. I don't need to worry about that section on the map. But the high transmissibility, again, as Kelsey pointed out, I'm very happy you had that because it fit right in with what we want to talk about. If there is a high transmission rate, and we know how highly transmissible and contagious these viruses are, then it's only a matter of time because people are not stationary, they are not sedentary, we are social beings and interacting. And while that's a good thing, it also means that we can't just pretend like those areas on the maps don't matter because they're not near us yet. And that also goes with short collective memories, along with being tired and confused or not always knowing things, and how quickly scientists have been able as a globe to come together, and we had infrastructure set up to get vaccines and information across the board so quickly in comparison to other pandemics in the past. I think it was confusing for people to understand. And since it's easy to forget things that are difficult to hold on to, or people want to believe that it's safe to go about our everyday, or that things are back to a normal, or that the pandemic is over, it doesn't mean it's true. We can want things badly, but it doesn't make it accurate. And that's the danger, along with just being tired. And that can go along with creating a sense of mistrust already with authority and intellectuals, past issues, past harm that has been caused to populations and individuals, in individual cases that are often sensationalized or not told and not shared with more than certain populations, or information that doesn't get disseminated accurately. And then that can also lead to mistrust of authority And then understanding is difficult when you don't have the ability to understand. If someone says something and it's not communicated effectively, or it's communicated in a way that it's about nuance or difficulty in understanding, or when someone says, I don't know, and they're supposed to be the person who knows, or you want them to be, it's also difficult. So that can lead to misunderstanding. And then again, with panic can come groupthink. So if a population wants something to happen, they'll try to form often an interaction or shape their environment to what they want. And so that doesn't even begin to talk about the very concrete lack of connections and access to resources and needs. So those altogether are a long list of difficulties that can cause deeply held and rooted beliefs or denials and acceptance in people. Sorry, so move on if we can. So this depicts a very old article or meme, rather, a historical meme of smallpox. So we see Compulsory Vaccination Act, death to vaccinator. So we see a policeman who represents authority coming in with a piece of paper that shows a compulsory act, or at least a perceived compulsory act to be vaccinated, or the fear of being forced to make a decision or do something. And then we see a trope of a young mother with a child, and then death as the skeleton. So it's forcing people who are considered idealized in society being pushed towards something that we know as a reality will help and protect them, but is seen as the very thing that will kill them. So people think that vaccines actually cause diseases and cause mass death, when we know that's not the case. We know it's the opposite, but it's a deeply held historical belief. So we can move on. And then, so early medical perceptions, public health and medicine science has changed. We now have ethical protections, improvement boards, biotechnology, increased access across the globe to one another in communication and information technology, and large data sets of information to work on and to build off of. So it's hard for people to understand when 1 week you're told one thing and another week you're told another thing. I totally understand that. And you have to really be on top of things. I'm actually very grateful again to Kelsey, because she reviewed things that I haven't had the energy or the time to review myself. So that helps me, but we're both, and I think a lot of people here are the ones who have access to education, to these resources, and to be able to interpret them the way that their insider perceptions, often communicate. And so there's a lot of problems with understanding the difference between group dynamics, population level issues, and individual issues. So, and then the differences between diseases and different organisms. So we see that with the Black Plague versus influenza. And now we have the scientific method that science doesn't always apply to that. And the method doesn't always apply to science, but more often than not, it will. Though that 1% of times when it doesn't is often held in memory because it's different, and people forget that. We didn't do forced quarantines in this country. We did isolation and recommendations, and we did not force people to get immunized, but people feel that requiring them in specific situations, they don't understand that difference, but there were arguments for it. And now we have different parts of medicine that really do understand just how important emotions and thoughts and our whole bodies are in our communities. And, a lot of these beliefs were built from eugenics or globalization and colonialism from the past, but that doesn't mean we have to continue it. It just means that we can use the information we have, but we don't have to make the same decisions. And again, that's hard for people to understand, especially if they don't even grasp or want to grasp the concepts of how real and ingrained they become within our society to create categories. So we'll move on again. And then I think this is also about washing hands. We need to do that. There was also a time when people thought washing hands, even doctors, when they were told to wash hands, made them angry. And they had fits and didn't want to do it, and it caused, a lot of death and harm. And it wasn't always death and harm. Sometimes even just causing an infection is not a good thing. Why would we want to cause active harm when we could prevent it? And then the Tuskegee Airmen, the case of men being, especially Black men specifically, being told that they were given treatment for an infection when they were not, or they were forced to participate in a study that they had no knowledge of. And the Belmont Report was developed in 1974 as an ethical board across the US to make sure that scientists were held to ethical standards. A lot of people don't know about that. And so you have to go through a whole review board, and there are requirements to even begin a study. And there's the perception that technology itself is causing diseases, or vaccines are biotechnology that would spread disease through this specific type of nanotechnology that is inaccessible, expensive, and incredibly difficult, and not really possible to coordinate in that way. But when you don't know what's going on and things seem bigger than life, or you want to question the basics and you don't quite understand the difference between individual perception and higher level information for population level, and not higher level, but large population or large systems, it's understandable that someone would try to figure out ways to navigate their lives in a different narrative or have a different perception of that. And so it's really important to connect with people where they are, think about what they're telling you, maybe take a few extra seconds to calm yourself, listen to what you're thinking, and things that, when you thought something, you were wrong about something, maybe try to help them bridge that gap, or don't. Just listen to them and give them time, and then encourage them to look at the world in a way that could help them connect to what their health or their family's health or their community are going through as well, and remind them that they're not alone. And often strength is considered a value, whereas, doesn't necessarily, strength is not always a good thing. Sometimes being so-called weak or vulnerable and showing we all have health issues, we all have things we need to manage, and we're in this together is very much a value. And just because you get sick doesn't mean you're a bad person. No one wants to get sick. No one tries to get sick. And so it's no one's fault that these things happen, but there are things we can do to help minimize or silo or control infections, which is what we're really trying to do. We're not trying to hurt people, we're trying to help people. So just reminding people that consistently in everything we do, in our behavior and our work, as much as possible, because we're human too. So yeah, I think we're ready for the next one. And then letting, like I said, let your feelings go for the moment, let go of our desire to control, because we can come off as just as authoritative in our roles as the ones that, like, white coat syndrome can cause or exacerbate these issues as well. Letting go of our fear of the unknown. I often get afraid when I'm talking to somebody who has a completely, what I consider off the wall perception of reality. Just reminding myself that just because I don't know what's going on doesn't mean that it's dangerous, that someone is dangerous. It just means that they don't know and they need comfort too. And then we try to assist people in getting access to information and to institutional needs and get those needs filled. And to remind people how much we can get from one another collectively and those regulatory bodies such as the government, that is a value. So yeah, ready to move on. And now I think I will hand it over to Yvonne finally. Thank you for being patient while I went through mine.
All right, thank you so much, Gray. So we're gonna look at the interventions and what type of things can be done to help our staff and help others with myths and their beliefs. And one of the things is to listen and really hear and try to get an understanding of what the person is saying. Gray mentioned the Tuskegee Airmen, and you will hear a lot of African American people talk about this, and that's their reason. And their reason is because of fear, not particularly that they don't trust this. They don't trust the whole process at all. So you have to listen and hear what they're saying before you can even put an intervention in place. And so understand their fear. And sometimes when you just talk to them about it, you can get them to see the reason for it and what happened at that particular time, and how what it is that's going on now is different. You also want to tell a story, tell them what you went through or someone that you know has gone through and how it helped them. And the last thing is you want to have empathy. So in having empathy, you don't want to feed into the myth. You don't want to say, well, yeah, I understand. And you know, you just want to understand, but you want to get them to understand that this is actually what's going to be the best thing for them. Next slide. So as you can see in this picture, this smallpox vaccination monster depicted here is visually striking, but is also a laughable image when we consider what is written here was that the smallpox vaccine was thought to cause additional disease like syphilis and cancer and leprosy. This is similar to the fears of today that vaccine causes birth defects, autism, and unlike today, this is probably or could possibly be one source, but now we have social media, you have people that they talk to, there's so many people that they're getting this from, and it's so believable to them. And so that's why it's so important to talk to them, to see where they're getting their information from, and make sure that you have information that's evidence-based so that they can get a real understanding and feeling for what you are saying. Next slide. So in this slide, you see where the mother is saying, oh, he's perfectly healthy, doctor. I agree. So let's give him some vaccinations, get some vaccinations into his system so that he can have a lifetime of problems. Well, when you talk to mothers, you have your mothers who don't feel that they should have their children vaccinated because of medical issues. They really feel like these things are causing illnesses, and that's one of the reasons why some people even today that may be working in the medical field don't feel that comfortable with getting the vaccines because they do feel like the vaccines are a threat. Next slide. So in this particular slide here, you can see that there's a lack of social connection and the access to education. And I like to talk about an incident that happened to me personally. When I joined the military, right before I joined the military, I was told by someone, don't let them give you the influenza vaccination because you're gonna get the flu. And so when I went into the military, I got the influenza vaccination with one of the largest needles I have ever seen in my life. And I got the flu. And from that point on, for years, I would not take the influenza vaccination because I truly believed that is why I got sick. And so I would tell people, oh no, don't take that vaccine because you're gonna get sick. I know it's true, it happened to me. And keep in mind, I had education. I was a nurse at that time. I just believed the hype. And because I got sick, I fed into it. Where later on in life, after I learned even more about vaccines and the purpose for vaccines, I did start taking the vaccine and was able to talk to people who had the fear and let them know I also had the same fear. And for years, I would not take it, but now I take it and I've never gotten sick from taking it again. Next slide. So there's the myth about the herd immunity. You'll hear where some people really truly believe that they don't have to have their children or be vaccinated if enough people receive the vaccine. The issue with that is that a vaccine is not 100%. So a vaccine will not 100% say that you're not going to get the disease, but it can help you from being hospitalized or being very sick in the hospital or even death. But that takes away from the myth of herd immunity. If they get it, then I don't need it. That's not true. So talking to them and finding out what they understand and what they believe and being able to talk to them about this a lot of times makes a difference in what the person believes. Next slide. So a lot of times we hear our staff talk about their children, and from the moment a baby is born, they are exposed to numerous bacteria and viruses on a daily basis. You'll hear that they shouldn't take several vaccines together, but it's actually better if you take several vaccines together. One, because the main reason is that the parents don't have to come back and forth to the hospital, and the baby is opened up to so many different diseases once they're born. So that's a thing that you can talk to them about as well. It's not dangerous to have your child vaccinated or to talk to your staff about them having their child vaccinated and having several vaccinations at one time. Next slide. And so COVID being an unvaccinated risk is COVID-19, the unvaccinated risk is a real risk. And I'm gonna talk about this without getting, try my best to talk about it and explain to you how this is. Now, my mother did not get the COVID vaccine. My mother, my sister, my family did not believe in receiving the COVID-19 vaccine. My sister took my mother to the doctor, and my mother caught COVID. My mother died from COVID. After that, my family got vaccinated. But should we have a death in our family? Should we have a death in our family before it makes a difference? So we have to be able to talk to people, let them know that you're where they are and you understand, and that it can make a difference. So excuse me, just know that being unvaccinated is a risk, and it can cause death to the people that you love, and you need to be able to explain to them how very important it is. You may not die. My mother could have went to the hospital and been okay had she received the vaccine, but because she didn't believe it, my sister who took her to the doctor didn't believe it, none of them received the vaccine, and now she's gone. So we're gonna move to the next slide. Excuse me.
Thank you for sharing your emotions and your, like I was talking about before, vulnerability. This is strength. This is meaning. So thank you.
Thank you. So today we just wanted to really talk about myths and how myths really do make a difference when people don't get to understand. So vaccines can cause the disease and death they are trying to prevent. That's just totally not true. And so that was one of the myths we wanted to talk about. Vaccines can cause additional disease and health problems, and that's not true. And vaccines are unnecessary illness is not to be taken seriously. And I read someone put in the chat that people don't even believe it's real. Some people don't even believe that COVID-19, none of this is real when it actually is real. And that is going to be it for today. Did anyone have any questions?
Yvonne, I would just echo Gray's comments. I'm so appreciative that you were willing and had the strength to share your story, I think, and that's really a perfect example of why we're here and why we're talking about these things. We have all been impacted in some way, shape, or form by COVID, whether it's a direct family member, whether it's somebody in our circle. I think, you know, beyond sort of our education in healthcare and public health and sort of in this space, and, you know, your story about the flu vaccine, I think was another great example. You were a nurse and you know, had this belief that you held on to that vaccine caused illness. And, you know, how do you sort of come to the other side of that to then be able to share that story back with people in that same situation is really powerful. And, you know, I think so. Angie put a comment here in chat that I think really ties nicely to that, talking about people, you know, that don't believe that COVID vaccines are safe and necessary, and are really citing this small number of people, whether it's nurses or doctors or other healthcare professionals that they really latch onto, that have come out and said, you know, we don't believe in this. We don't think it's, you know, it's not a problem, that we don't need the vaccines, or really sort of like downplaying that. And I think, you know, in your example, you were a person who had that education and had that training, and, you know, were sharing with others how you didn't feel like it's necessary. And so, you know, while we don't know who these people are necessarily, right, who are, you know, maybe the 1% or 0.05% who are sort of spreading some of this, I think it is really difficult to sort of come out on the other side and share that data, share those facts. And, you know, the point about, you know, yes, we can share this, but like, how do we get through to them? And, you know, I think both you and Gray provided a lot of great insight and framework about how to have these conversations and how to just listen and really understand where people are coming from. But I think, you know, to some extent, it does take some sort of event or something happening to you personally before you can sort of, you know, rip that Band-Aid off and say, okay, you know, this really has opened my eyes to something different or something new. But that said, I am curious for others on the line. I know Angie's not the only one hearing this or experiencing this. I mean, have you found anything that has been helpful for you to try to get through to people that just really have this firm belief of, this isn't real, I don't need the vaccine, this, you know, isn't going to protect me? Anything you've done to combat that you feel like has been helpful?
And if no one else has a response, I can share a couple examples of my own too. I spent the beginning of the pandemic working with the Detroit Health Department and the International Collaborative of Scientists Testing in Nursing Homes in Detroit. And I don't like to go into detail about my experiences because it is incredibly detailed, but if people want to hear my story at a different time or reach out to me, that's totally fine. The reason why I point that out is because I was also working in a Medicaid market and speaking with patients every day throughout the pandemic. And while it helped me get through the pandemic and being isolated or, you know, having to distance ourselves physically, I was able to speak with people who, even after having deaths in their families due to COVID or being disabled themselves due to COVID, were still in denial that it was COVID or that it was severe or that they were affected at all. Or and I had a few times when I just spoke to people about how I felt instead of giving facts or giving anger, because you can feel angry. And I think that's totally healthy and justified to be angry. There's nothing wrong with that. But if someone doesn't respond to it, just giving them your story. And if that's how if you listen to how they got connected to like a famous YouTuber or a conspiracy theorist or some kind of misinformation, if you kind of communicate with them like that, there were times when I was able to say, this is how I feel, and this is what I'm worried about. And it's because I care about you, not because I'm trying to control you, not because I'm trying to tell you what to do with yourself or who to be, or that I'm trying to make you feel bad because you don't feel the same way or think the same way as everybody else. It's because I care, and I don't want you to go through further harm or anything else to happen, no matter what it is. And meeting people in that feeling or those moments of unknown or uncertainty, and allowing them to have that space is really what has always helped me with the hardest of cases. And I won't get everybody, you never will, but getting one person to understand is what we can do sometimes, and that matters.
And Gray, I think your point, yeah, and I think your point is well taken about just giving people space and trying to understand. And I feel like particularly in our world lately, it's been sort of this like browbeating of you need to get vaccinated, you need to get vaccinated, it's important to get vaccinated, and not really taking a step back to understand and meet people where they're at and walk with them through whatever they're going through, whatever reason, justified or not, that they don't want to be vaccinated, they're scared to be vaccinated, or whatever that case may be. And, in my mind, as educated healthcare professionals, we know what the science is, we know what the data is, but not everybody thinks that way. So to your point, right, sharing those personal stories may be more effective than saying, here's 5 research articles that have been published last month, and expecting people to read that and digest that in a meaningful way, I don't think is appropriate. And, you look at some of the other sort of myths or misconceptions that people hold from, the Holocaust didn't happen till the earth is flat, right? And we all have our own opinions, some of which are based in science, about what of that is true. And I think, to some end, we're not going to be able to change people's minds. And so taking a step away from this, like we're beating a dead horse about COVID vaccines, you can't force people to do things. You give them the information and the tools and the space to process, and you just kind of got to let them go and make that decision on their own with their families, with their care teams. All you can do is guide them and equip them with that. And the rest is, they got to cross the finish line.
And reminding them that scientists are people. We never work as individuals. We always work in groups. And if someone's telling you that their opinion is the one that matters, or that they should listen to you, chances are that's probably not a reliable source, or they might be a reliable source, but you got to listen to other people too. It's the collective that makes the decisions oftentimes. And reminding them, yeah, doctors aren't God. No one is. And if they don't feel comfortable with their doctor, or if maybe their doctor is telling them that they don't need to get vaccinated, maybe there's nothing wrong with getting a second opinion and asking someone else why or why not. And I think people are scared to do that. And that often helps people. And like you said, just saying, it's up to you, letting people know that someone supports them making that individual decision, that is where I see the biggest change.
Mm-hmm. And I do just want to jump back to Jennifer's comment, and I know, Gray, you responded in the chat.
I could.
But, I like this comment a lot, and I think there's a lot to unpack here. So, the first is sort of this incentive of, well, if I get vaccinated, then maybe COVID will be done and I won't have to mask anymore. I don't have to test. But when you do that, you still get sick. You still have to test. You still have to wear your mask. If you weren't really on board with it to begin with, and now, none of those sort of downstream consequences are happening, I think it can be hard, and I can fully appreciate, this perspective and where these folks are coming from about, why would I do it? I might still get sick and I still have to do all these other unpleasant things. Like why, right? And so asking that question and having that crucial conversation, I would call it. I can appreciate why there are staff who, might be reluctant to get another booster or have that feeling of, okay, maybe, we even see this with flu, right? Annual flu shots is already hard enough that getting a COVID booster every 6 months is like, forget it. This is never going to work long term.
Yeah. And now with monkeypox, it just seems like it piles on. I totally get that. And I think it's scary for people who don't understand or maybe do have real side effects that affect them and continue to affect them over time. Even if it's just a day or two, sometimes people feel like getting all 3 shots in one day might be too scary or too much of a risk. And they might be right. And that's only something they can talk with their doctor. But there are, people who can do all 3. And that's why they offer it that way for people who can do that. And things, again, will change. And I think that'll be yet another source of frustration and confusion. And so it's got to be tough. But I just say take things, day by day, remind yourself it's new conditions and we're doing our best. And so I would say to someone like that, do you just stop washing your hands? Do you stop changing people's diapers or their briefs? Do you change your underwear every day? Things like that. Hopefully over time it can become just as procedural. And while also understanding that it's difficult to grow up, it's difficult to create new habits, but we'll be stronger for it. And we'll be better for it in the long run because we won't have stinky underwear, hopefully. Something to make them laugh and try to make it a little easier.
Yeah, a little more lighthearted.
Maybe not appropriate, so I apologize for that. But.
So I just want to pause and invite any of our other participants on the line. If you have other verbal comments you wish to make, I would welcome you. Just unmute your lines and share. But I think this has been a really robust conversation. And Angie and Jennifer, thank you so much for your comments in chat. I think you're spot on, and hopefully some of the tools and information we've shared today will be helpful. But again, just want to pause and make space for those who might have additional comments or input for our conversation.
Hey, Kelsey, I just had one comment, and this is sort of more on sort of what I've experienced in my household. So, and I'll give the example, and this might be impacting some of your staff. If they don't have an opportunity or their family members don't have an opportunity to receive a booster vaccination, within their home organization, but, my spouse went to go schedule his booster vaccination, and he's like, I didn't understand, like, which one was it? There were like 3 different options, booster 1, booster 2, booster 3. So I think there is an opportunity, I think sort of in that healthcare setting, and that speaks to sort of what Gray mentioned, is talk to your physician and understand sort of how you go and schedule it. But I think that we still have an opportunity to improve sort of the scheduling for that and sort of knowing which vaccination I should be getting for myself and how do I go about scheduling that. I still think there might be an opportunity to improve that.
So Jill, I apologize. Your audio is breaking up quite a bit, but I just want to see if I can sort of repeat what you shared. And again, I apologize. I only caught bits and pieces, but asking your physician about.
I think I got a summary here.
Right. Thank you.
Jill I tried to transcribe. So Jill, if there's anything that I missed or that you want to correct, please let me know.
Will do.
Cycling of information, knowing which vaccines we're getting and why or why not. Yeah, and I think that's a great point, particularly for people who might not be as healthcare literate as what I think most of us take for granted. And just understanding, as I'll even ask friends, oh, have you had, this booster or that shot? And they're like, I have no idea. And so, really just helping guide and understand, right? Like, what have you had? Have you had a COVID booster? If so, was it the monovalent booster that you got maybe in March or April, or is it a bivalent booster that you got last month, right? So like, what does this look like? And even trying to help sort of broad picture, lay out some of those recommendations and guidance, I think can be really helpful. But, Jill, to your point, right, working with your physician or your care team to figure out what have you gotten? What do you still need? What are you due for? Whether that's a COVID booster or your pneumonia or your influenza or Tdap or whatever, just having that understanding of where you're at, if you're up to date with what you need for COVID and beyond is really important. And I think one of the other nice things too with COVID is that you can sort of mix and match, right? If you got Moderna or you got Pfizer, you can get the other one. So I think that gives us as imperfect humans a little bit of grace and wiggle room. So if we don't remember what we got last time, it's okay, because we can get whatever else is available.
We have collective records, and I'm actually someone who's a little afraid to get a different type of vaccine than I've gotten before. I'll be 100% honest about that. I have gotten Moderna the whole way through, and I know I should get that Pfizer, so I have to work that. I have to work myself up to that. That'll be my next one.
Absolutely. All right. Any additional comments from the folks on the line? All right. Well, Gray and Yvonne, thank you so much for a great presentation today. I think this has been really informative and really engaging. Thank you to those who have put comments in chat. Jill, for your verbal comments as well. And again, I know this is a really tough subject. I know this is something that we wish we had more control over, but I'm hopeful that some of these sort of framework that was provided will be helpful in how you approach these conversations and how you sort of open the door and invite safe conversation about this, because it is tough and people have their own ideas and beliefs and opinions. Jerry, I know you've put the link both to our survey or evaluation as well as the slides. So for folks on the line, just take a minute to click on both of those before we disconnect. Otherwise, wishing you all a great rest of your week. Happy Halloween, and we will see you next week.